It really is an honor to be here, and I must say, even as a resident, I remember and working at ISIS hearing about Knapp Craig and the work, and certainly when Arlene came down, Arlene's somebody I've sort of known and admired for so long, and so to be part of this plenary today is a real honor, and of course to David for the invitation and his tremendous leadership in the Greater Toronto Area, not just in our division. So I do want to talk a little bit about our work in primary care, but when I first took on the job of health quality in Ontario, I met with a very nascent organization in my first 5-7 days on the job, and an organization called Patients Canada. And the leader at that time, a guy named Shalom Gluberman, said, you know, you should never go and talk about the quality in the healthcare system without starting with the voice of the patient. And so I try to do that. I don't always succeed, but I do try to talk about it. And I want to start today with a patient from my practice from downtown Toronto, a guy I'm going to call Scott, not his real name. He's 51 years old, and like all of the patients in this particular practice that I work in, he's a homeless man at Seton House. Seton House is the largest homeless men's shelter in North America. It is actually due to be renovated after decades in the next few years. Like all of the patients in my practice, or the vast majority, he has significant mental health issues. He has schizoaffective disorder. Like many of the patients in my practice, if not quite all, he has substance use disorder, in this case, nicotine and alcohol. Primarily, and like I said, he's 51 years old. He's got an undergraduate degree, actually, and a licensed street performer. And Scott was staying at Seton House, this homeless men's shelter quite close to my clinic, just a couple blocks. And unfortunately, he began to drink very heavily. And he drank so to the point that he really wasn't caring for himself anymore. He was sort of getting into altercations. He wasn't eating at all. All he was doing was sort of binge drinking on alcohol. He couldn't care for himself. And so the team brought him into our clinic, and he was seen by one of my colleagues, who's his MRP, and she realized that he was really in a state of distress and made the very difficult decision to place him under the Mental Health Act. For those in Ontario, we'll call it Form 1. He was formed, he was brought by the police to the emergency room. And in the emergency room, he was actually then admitted to the GIM ward, the General Internal Medicine, and then to psychiatry, saw him. And he decided to seek care. And he wanted to go into rehab again, into a withdrawal treatment program. But here's the tricky thing. In the Greater Toronto Area, you actually can't get into a treatment program unless you have a fixed address to go to at the end of your treatment program. Lots of heads nodding. This is a familiar thing. So that's super, unless you're homeless. So his MRP, his family doctor, did a really sort of worked above and beyond and actually called a bunch of shelter systems and actually found a shelter system that would bend their rules and say, you know what, we will save a bed for 7 weeks down the road when Scott leaves his treatment program, and we will guarantee that he has a bed, which actually is not what they do. They actually have rules not to protect beds because, you know, if they don't show up, they've lost a scarce resource, and 7 weeks is a long time away, and who knows what urgent need will come up between now and then, and how can they resource, but they did. So he went off to the withdrawal program, and by all accounts did quite well there, participated in the various therapies. But unfortunately, immediately upon his discharge, began to drink again extremely heavily after 7 weeks of sobriety. And to his credit, he did make it to the shelter bed that had been reserved for him, but it was a dry shelter. So he was turned away. He continued to drink quite heavily and made it, to his credit, to another shelter bed, which was not a dry shelter. It was busy in that shelter, and they gave him a mat on the floor in the overflow room. And over the period of several hours, he lapsed into unconsciousness and died. And I share this story with you for several reasons. The first reason is at the age of 51, he actually outlived the life expectancy for a homeless man on the streets of Toronto by about 2 years. The average life expectancy on the streets of Toronto is about 48, and for a woman, it's about 41 years old. Some of them freeze to death, which some of my patients have. I appreciate in Washington, D.C. on a day like today, that seems like an impossibility, but it does happen in the streets of Toronto in the shadow of billions of dollars of healthcare. And they die from overdose and they die from violence. One of my other patients was actually beaten to death with a rock 3 weeks ago at the age of 48, right on time. And so that's the first reason, is that we have tremendous inequity despite the richness of a primary care and specialty care system in the streets of Toronto. The second is that in a lot of ways it's great quality care. What do I mean? I mean that it would have been very easy for the folks at Seton House to simply say, you know what, you're sort of gone off, you're drinking too much again, Scott, you can't stay here anymore, when you sober up a bit, we'll take you back, out the door. But they didn't. They made sure he got to my clinic. And it would have been really easy for my colleague who's a family physician to say, gee, Scott, things are a bit rough. You know what, you should really sort of ease off a bit. If you want to talk, if you want to go to treatment program, let me know. Otherwise, you know what, see you in a couple weeks when you're sort of through this binge. But actually made the very difficult decision to form somebody, to remove their rights and to place them under the Mental Health Act. And actually that as a family physician in our therapeutic relationship is always a difficult decision to do in a primary care setting. The police came, and I am aware that your country, like my country, when it comes to those with mental health illness and those with addiction illness who interact with the police, often don't have the easiest of interactions or the safest of interactions. But in 51 Division, which looks after our area, they actually have very specific training, and specific police officers with training in mental health were sent out, and without the use of force, de-escalated the situation, and Scott did get agitated and a bit confrontational. Without the use of force of any type, de-escalated, got him into the back of the police car, and got him to the local emergency room. The emerge could have said, here's a sandwich, here's some IV fluids, do a couple blood work, out the door in the morning, but they admitted him to a scarce resource bed, and so on and so forth. And in many ways, it's great quality care, but at the end of the day, somebody who should not be dead is dead. And this brings me to one of the greatest cruxes of the quality challenge that we have in our healthcare system. It is the passage through the system of particularly complex patients where the greatest quality gaps occur. I feel increasingly, not that there isn't more room to do, don't get me wrong, I'm not overstating the quality of care we have, but I do believe within any given sector, we're doing better at managing quality. But as we look at the gaps between our healthcare system as patients move from hospital to rehab, from rehab to primary care, from primary care to home care, et cetera, that's where the quality challenges are often greatest in our healthcare systems. And this is a really prime example of somebody falling between the cracks, because there is no CEO who will look after this. Is it the hospital? Is the emerge going to say, oh boy, we did something wrong? No. Is the primary care doctor? Where is the gap in this system where there is a CEO and a board who has accountability to understand what went wrong here? There isn't one. And the final reason I tell this story is because the way I heard that Scott had passed was my colleague sent out this email to our small group of us who work in this very, very small family health team and said, could somebody please look over this chart and tell me what I did wrong? Can somebody look over this chart and tell me what I missed? Would a couple of you sit down with me, and could we make a plan to make sure that this year we don't have any more Scotts and figure out what we need to do differently? And we talk a lot about data, and we talk a lot about studies, and we talk about run charts and PDSA cycles and QI measures. But what we have to remember is that when we fail in the quality of our healthcare system, we fail first and foremost our patients. But second of all, we feel those failings very deeply ourselves as healthcare providers. And that our journey on the quality improvement process and the journey we have as researchers and policymakers and advocates is to help support those who are on the front lines every day, who try so hard to provide the best of care and feel so deeply, often for years later, the failings of our system when they happen. And that's what quality care is about. So I know there's a wide variety of people in the room, and I thought I'd take a few minutes just to level set. So first of all, primary care in Ontario. Ontario is a big place. As I said in the abstract, the entire country of France could nestle quite comfortably just up in the northwest part, never mind the rest of the province. There's about 13.5 million people. It's incredibly diverse in terms of large urban settings like Toronto, which have 4 to 5 million people, and towns that I spent the first decade of my life working in of 700 to 3,000 people. We have Aboriginal. We have a large portion of new immigrants every year. I must say one of the most interesting things to see in my homeless shelter change over the last 8 to 9 years has been this incredible shift from sort of the classic, what we would talk about as street people and alcoholics and Aboriginals, to a large number of refugees, not just from Syria, but from elsewhere in the world, now staying in the homeless shelters. It's been a fascinating demographic shift. So we have Aboriginals and our First Nation people up in the north and in our urban settings. We also have a large number of immigrants coming in as well. There's about 12,500 family physicians. There's about 1,000 nurse practitioners. We have literally probably over a dozen different primary care models. About 10 years ago, 80%, or probably even higher than 80%, would have been probably closer to 90%, would have been on fee-for-service. At this point, the vast majority are in some type of non-pure fee-for-service model. So we really have over a dozen models, the vast majority of which are in different payment models other than fee-for-service, a lot of team-based models. We do now have, and this has been a huge sort of catch-up for us, a large number of EMRs, but for the large part, and there are some now beautiful exceptions around Utopian, around Sipson, and again, we have leaders in the room in this area, we have a hard time getting meaningful use out of it. We have a very, very hard time, and we are at the nascent edge with a nice, beautiful, but small examples still of trying to get good data out of our EMR, both for research and for QI, and where the two intersect. But we still lag, I would say, many jurisdictions in the world in our ability to do this. There may be those who disagree, but I feel pretty strongly about that. We do have large numbers of the population able now to get team-based care. So again, I always argue that the most important person in my clinic is the chiropodist or the podiatrist, because I have a high Aboriginal community. They have a high rate of diabetes. They have a high rate, therefore, of foot ulcers in the winter as they sleep outside. The risk of lower limb extremity infection and ultimately loss is disproportionately high. And therefore, if they're going to see one person in my clinic, it's not me that's going to sort of futz around with another 2.5 of Glumetza. It is actually the person who's going to keep them from losing a lower extremity, and that's their chiropodist or their podiatrist. So again, we're doing more and more of interprofessional teams, but not enough. It still matters where you have the fortunate nature to have your primary care provider. And so again, we've made progress, but not enough progress there. So a little bit about Health Quality Ontario. There is quite literally, for better or for worse, nothing else quite like it in the world. There are places in the world that have elements of what we do, but nobody has quite everything we do or structured in the way we have it. So we are an arm's length government agency. We look at evidence, we support quality improvements, and we do public reporting, everything from the level of the individual provider right up to the healthcare system as a whole, with global comparisons to other OECD countries or whatever. And so a wide range of different activities. For better or for worse, it often feels for worse, but I'm sure it is for better. We don't have a lot of sticks. We don't have a lot of sticks. I don't control people's money. I can't cut anybody's budget for, failing to hand hygiene. I can't cut anybody's budget because, they don't look at their data. I don't have any regulatory power. I can't sort of say, wow, your C. diff rates are 5 times the average. I can't cut your funding. I can't regulate you to be better. So we really are in the carrot business. We are in the business of suasion. We are in the business of using leadership. We are in the business of using data. We are in the business of using common sense and the tools and the science of quality improvement to improve the quality of care. We do not have a lot of those classic hard sticks that perhaps we would like to as well. And of course, the question is, why do we need an agency focused on quality? And the answer is because we're not very good in Ontario in quality care. And this is this sort of classic OECD graph. I think this time I actually borrowed it from a slide that Rick Glazer used. But I see this slide everywhere. I've seen deputies of health use it. And this is looking at OECD countries. And the only thing that we feel really great about in Canada, and we look at this graph very, very carefully on, and are very quick to point out in any and every setting, is we're actually not bad if you look at the US. That is Canada's inevitable response to any data on healthcare. I hear what you're saying, but have you looked at the US data? And so we actually sometimes take the US out, and we just cover that last chart, that last column, and then we can have a very constructive dialogue about the opportunity for improvement. Because otherwise we say, oh my God, we're spending 12% of our GDP on healthcare. People say, have you heard about the United States? They have a wall. And, but if we shutter ourselves to the neighbors to the south and look at sort of anybody else, we have a long way to go. We have a long, long way to go. And then people inevitably say, oh, Tepper, get on your SSRI. Is there nothing good about quality care in Ontario? So I actually say there's excellence in Canada, there's excellence in Ontario, but what we have is massive variation. And I think the Dartmouth Review and people like Therese Stuckel, who've now come up to ISIS, spelled with a C, not an S, have really helped us see, is there's actually great examples of good quality care, but we don't have as a normative standard of care. So this is just one of thousands and thousands of examples I could give, literally. This one is long-term care, just to stop picking on primary care for a few moments. And this is 600 plus, almost 700 long-term care homes, and this is in Ontario, and this is the use of antipsychotic medications for those who actually are not psychotic. And there is actually almost no indication for that in the drug approval, except for like an incredibly narrow one. And what you see is, depending on where your mother or father might be in a long-term care home, the odds of them being on an antipsychotic are anywhere from about 4% to 68%, right? Like, it is unbelievable. And some of that can be sort of arguably case mix adjusted away, but not much. If you have a low-risk pregnancy, like truly low risk, one baby at term, pointing down, healthy mom, healthy baby, all good, the C-section rate for that nice low risk in Ontario alone, and our 100 and some odd hospitals that do C-sections, is anywhere from 4% to 38%. Like, it is staggering. And that is clean data that has been risk adjusted to the point of nihilism, right? And but many papers came out of it, I'm sure. And so the problem is not that we don't have good quality care; it's that we don't have a standardized level of good quality care that people can expect regardless of what primary care practice they walk into, what long-term care practice their mother or father is, or where they go to have their baby, et cetera, et cetera, et cetera. And so the variation is really our Achilles heel. And when you then stratify by urban, rural, indigenous, non-indigenous, income, et cetera, you actually begin to have not unexplained variation, but explained variation that is fundamentally worrisome to a society and a country that prides itself on social access to healthcare. And it is a deeply worrisome feature that we need to address in our quality agenda. So when I talk about quality, I talk about equity a lot. So how many people at one point have heard of the book? And this is where you go from heard to I actually read it in one sort of head nod. Good to Great by Jim Collins. There you go. So it's a great leadership book. When I got into the MBA, I thought I should read at least one book before I showed up with all these sort of other, bankers and consultants and IT people from IBM. And so I read Good to Great. It's, stood me in good stead. I probably could have saved 85 on K on the MBA and just read the book. And in the distal third of his book, he talks about this idea of a flywheel. And this is a picture of a flywheel. And he talks about a flywheel as being this incredibly large, heavy wheel that is really hard to get going, But once you start to get it going, the momentum of it and the weight of it actually makes it spin faster and faster with less and less effort. There's a physics equation, but I went to McMaster, so the physics was not required for me. You can tell who the Canadians are because they get that joke. But that is the base of a flywheel, and it is used in numerous examples in sort of machines of all shapes and sizes. And I often think about the quality improvement journey as being a flywheel. It's incredibly hard to get going, but if you can get it going right with the right ingredients and the right muscle behind it, it will get easier and easier to do, and the wheel will move faster and faster, and I'll get it going. So what I'd like to spend the next 2 hours talking about is, I'm kidding, honestly, are some of the things we're trying to do in primary care in Ontario to get the flywheel going. These are 6 initiatives, 30 minutes each, that I will be talking about that we are trying to do just in primary care to get the flywheel really, really moving. And some of these are early days, some of these are later days along the way. But the very first thing we actually had to do was actually to say, well, what the heck does quality actually look like in primary care? Because when we looked at home care, when we looked at long-term care, when we looked at hospitals, we actually had like tons of agreement on what we should look at. Now, was there total agreement? No. Do we need to clarify some of it? Absolutely. But when it came to primary care, we didn't actually have a starting point even, and people like Rick Glazier literally spent years working with us and working with Health Quality Ontario to try to come up with a clear measurement framework of what are a few things that we should collectively work on. And we'll revisit it and we'll drop a few indicators, we'll add a few indicators, but we at least need to have a common language of what the heck we talk about when it comes to quality in primary care. And what are the dimensions and what are the indicators and what is their accessibility to that data, and are these future, are these aspirational, what could targets be, et cetera, et cetera. And so a lot of work just to create a primary care performance measurement framework was done, and it literally took years. But it's a really important first step, because if you don't know where you're going, you're sure to get there, as Yogi Berra said. That's my only American reference. Practice reports. The other thing we've started to do is we've started to make available to any family physician in the province, regardless of practice model, a personal private report that comes to your email that says, across 20 to 30 indicators, here's how you're doing. Here's how you're doing against other people in your practice, other people in your region, and other people in the province of Ontario. And if you're not sure you're happy with where your performance is on these 25 measures, immunization rate, pap smear, colon cancer screening, access time, like we got a whole bunch of things in here. Here is some evidence-based quality improvement tools and resources to do better. Because I think one of the worst things you can ever do to somebody is say, you're doing poorly, fix it. Good luck with that. And even worse, I'll be back in 3 months to tell you that you haven't improved. You have to offer to help. Like, we'd never tell our kids, you didn't do well there on that math test, do better next time. You sit down and you say, here's how we do better. Here's some assignments. Here's some exercises. Here's what better looks like. Here's some coaching. Here's somebody who's got it figured out in the class. And so we make sure our practice reports don't just have the data for themselves, they have it in comparison. And we provide QI tools that we know work and that are free and easily accessible on websites and relatively easy to implement. The next thing we have done is we've tried to help people involve the voice of the patient. And I know we've got a fantastic plenary speaker talking more about the evidence base and his research in this later today out of Montreal. But we did a large survey and a review of patient experience surveys literally from around the world. We took a look at the best ones, we boiled them down, we picked some questions, and we got it down to about a 12-point questionnaire that we now can sort of say, if you want to hear from your patients, here's a 12-point set of questions that has a good evidence base around it. Here it's free of charge, download, and even if you don't want to use all 12, pick 3 or 4 that you can start to involve in your practice. The other thing we're making sure that we do is we involve patients in everything we do. So when we set out that performance measurement framework, there were patients on those committees for several years saying, this is what I think matters. Every time we put out a report on primary care, there are patient stories everywhere in it. There's provider stories too, but there's data and there's narrative.
And so we involve the patients and the voice and the experience of the patients in our work very, very integrally, just as I tried to start, or I did start, with the voice and experience. The next thing we do is we try to actually give the skills to do QI. And again, like I said a little while ago, giving people data is insufficient. And in fact, it's unfair. Telling people they're not performing well, but without giving them the tools to do better, is unfair. And one of the arguments I've made to our medical schools and our nursing schools is that about 15 to 20 years ago, we made a decision that no one should graduate without knowing what a p-value is. We made a decision that nobody should understand why an RCT is a lot better than anecdote and different than a case study or a cohort study. We made a decision 20 years ago that nobody could ever get a license to practice medicine in Canada without understanding what the number needed to treat is. And equally importantly, the number needed to harm. You don't pass your boards without understanding that. You don't. You want to be a doctor? Figure that out. Why? Because it's part of what being a responsible doctor is. A responsible nurse practitioner, a responsible nurse. And what I think we need to say now is nobody graduates anymore without knowing what a run chart is. Nobody graduates anymore without knowing what a PDSA cycle is. Nobody should graduate anymore without knowing what a fishbone diagram is. Why? Because that's how we get better. And if you're going to go into healthcare, you go into healthcare not just to provide care for today, but to actually do better. To do better for our patients tomorrow, and to do better for our patients next week, and to do better for our patients a year ahead. And there's a VP of quality, internalist named Alan Forrester out of the University of Ottawa, a really nice guy, and he talks about quality a lot. And he'll say, there's always somebody in the back of the room. He says, Dr. Forrester, do you really think we go to work every day hoping to hurt people? He says, no, of course not. But am I convinced that you go to work every day hoping to do better for people? That I'm not sure. And part of the reason that's hard to do is because we don't give people the skills. We know how to critically appraise a journal article. Do we critically appraise absolutely everything we do? I admit I don't. I appreciate several people are nodding, yes, I do. I don't. Right? I don't peer review everything I do. But now and then when there's something new out, I take a look at it. Or when I see a journal article that's really going to change my clinical practice, I sort of take a quick look and I try to test it a little bit against the basics. I'm not a huge ClinAppy guy, but I got enough to know. And I don't expect to quality improve every aspect of my practice every day in a relentless fashion. But boy, I should be thinking about one thing I'm going to tackle every 6 to 12 months. Just one. And I should know what that looks like. So we run a program called IDEAS. It's got a big acronym that I never remember, but somewhere is improvement and quality. I don't know where the Q is, but it's in there. The Q is silent. And we basically have we have a big intensive multi-week course. We have a 2-day course that's offered by all the medical schools in the province of Ontario, all 6 of them. And then we have alumni programs to refresh and keep the network of people who've graduated up to speed and doing more advanced quality improvement and improvement science training. So what we'd love to do is see every organization, whether you're a primary care practice, a long-term care home, part of a home care delivery agent, certainly a hospital, any part of the healthcare system, have a cadre of people who have the basic skills of quality improvement, because that's the path to better, part of the path to better. The other thing we've done is we know that no change ever happens without leadership. And so we've started to actually hire quality improvement specialists. We hire them in conjunction with our regional health authorities. And we know that it's really hard, especially within the physician leadership group, not to have peer-to-peer leadership, not to create networks, not to create communities of practice. We need places, we need incubators where people can stand out and lead, where people can come together and talk, where people can come together and share ideas. They can curse the acute care centers for their lack of interaction with primary care. They can mutter things against orthopods or whatever it is. And we have started to invest quite significantly on leadership and quality improvement, and to create safe spaces virtually and in person where people can come together and do the work of quality improvement. And it's, I think, sometimes easy in the morasses of data and the shininess of IT and the power of regulation to forget the transformative nature of good leadership and how important it is to have that person. And often it can be somebody, even a patient, to lend their voice, to lend their authority, their soft authority, not hard role authority, but their soft authority of experience to bring and to participate in these quality improvement pieces. And quite literally in this room, we have in Canada several of the people, and I've mentioned people like Michelle, I've mentioned people like David, who was kind enough to introduce me today, Arlene, who you've kindly repatriated, but we miss, but we may get back coming in. And then the last thing is a really interesting thing. I don't think there's another jurisdiction in the world that does this, which are quality improvement plans. And this is the one sort of regulatory power that we have, which is a requirement that almost 300 primary care practices, so all of our team-based models, every year must submit publicly a plan for improvement. And those roughly 289 primary care plans go in with about 600 long-term care plans, several dozen home care plans, hundreds of hospital plans, such that right now in Ontario, every year we publicly post on our website well over 1,000 quality improvement plans. They're a public commitment to better. They include targets, and they include measurement about the targets. They report back on how things are going. And I do believe it is the largest jurisdictional effort that's formalized to actually talk about and move forward quality improvement in a very centralized way. Obviously, millions of quality improvement efforts happen, but this is all ultimately coordinated and organized through one body, which is Health Quality Ontario. And it has been fantastic to see the level of sophistication and the level of involvement move over a period now of 3 or 4 years where this has been happening. And again, they can look and feel very different. And for a period of time, as was mentioned, I was the Vice President of Education at Sunnybrook. And Sunnybrook lives in an incredibly wealthy postal code, or zip code as you all call it. And it's a very wealthy zip code. And I had a family practice, a part-time family practice there. And you know, my patients lived into their 80s and 90s. Like, these people had every social determinant of health you could imagine in their favor and benefited from it. And so I was dealing with incredible complexity. I had these 89-year-olds on 14 or 15 different medications who were surviving with numerous chronic diseases, including dementia, really difficult, complex, vulnerable elderly, as the literature likes to call them, patients. And I literally would drive about 5 kilometers down. Fortunately, it was down a hill when I biked it. Turns out it was uphill the other way, which was unfortunate. Down the hill to my homeless practice, where, like I said, the average age is 48. Smoking is the least of their worries, realistically. You know, HIV, hepatitis C, mental health issues, polysubstance use, incredibly huge. You know, really completely different. But both of those family health teams had to fill out a quality improvement plan. And both of them had to focus on the similar dimensions of quality. They're night and day in their patient population, but they both made a commitment to quality in the same form, in the same format, feeding up to the same organization. And they both did it. They just looked at very, very different things and in very, very different ways. And so I think these quality improvement plans, which now cover about 25% of primary care, have been a really remarkable experiment that Ontario has been undertaking. And again, it's not just in primary care, as I mentioned, but over 1,000 healthcare organizations now. A lot of what we do succeeds. In fact, I would say everything we do succeeds only because we do it with others. One of my taglines when I first got there was, quality is a team game. And so this is just some of that quality framework piece, so one of those 6 things that I just talked about. But we work with people literally in all parts of the healthcare system, including patient groups and patient advocacy groups and patient representative groups, researchers. Government isn't on there, which I found interesting when I looked at the slide last night again, but we do. And just, it really is a huge key to our success. And we do leverage tremendous expertise and leadership in our work. So, there's a lot of reasons why being invited today is such a privilege to speak. And it is a real privilege. But one of the things I find it's a privilege is a time to step back and reflect a bit. A chance to, the responsibility and the privilege of giving a talk like this is you have to take a few weeks to think carefully about what you want to say. And I find that thinking about this and preparing for today was actually a chance to really step back and sort of say, like, what are we doing right? What are we doing wrong? What we could do better? And a couple weeks ago, a researcher named Walter Wood just flagged me to this JAMA article, which talks about how do you manage change in the health system. And quality improvement really is about change. At the end of the day, quality improvement at its essence is a change exercise. It's about doing something different tomorrow than we're doing today. And this JAMA article sort of talks about, they talk about 7, and I've added one that's the yet unpublished and probably never to be published appendix to this modification to this highly published JAMA article called Tolerating Failure. But the first 7 are out in the press. And I actually sort of stopped. I said, how are we doing in the province of Ontario against these 7 things? I think we're really strong on trying to establish aims about improvement with the quality improvement plan and the performance measurement framework, and I might give us a 7.5 there, because there's still a degree of granularity, particularly around some of the social determinants and equity and the disparities we have that need to be addressed. And so I think we need to have an even sharper aim, which is hard when healthcare is so large and so complex to get this aim, and how do we find that tension? But we're not doing bad there. Where I can tell you we don't do very well is a plan for spread. Many people have been attributed to this quote, so I don't know who said it first. But Canada is a country of pilots. We love our pilots. We'll run it out for 10 family health teams. We'll run it out to 8 primary care practices. We'll get crazy and roll it out to 50 primary care practices and run it for a couple years. And then it just sort of stalls, even if it works well. And so we run pilot after pilot, and we're not sure how to set things up for spread. And in fact, what happens often is we overbuild the pilots. We put high-powered researchers and evaluation, and we just, add extra FTEs, and then we want to go and say, wow, when somebody got their New England Journal and their academic promotion on this, let's go crazy and roll it out. We can't, because we've overbuilt it to the point where we can't actually roll it out into a practice of like 2 family doctors working in a town of 300 people with 1 nurse. We don't know how to do that. And so I think I give us a sort of 3 out of 10 on that one. And the others are somewhere in the middle. We do tests of change, but often we don't. Often we go all in. You take a look at a place like Google. At any time, they're probably running about 40 different versions of that algorithm, if not more. And they test the algorithm. Apple will roll out 70 different sort of types of variations of their models and run them for 90 days, run them for 120 days, run them for 200 days, tweak them, cut them, stop them, try some new ones, stop them, try them again. We tend to try one test of change. We have a problem with, follow-up at 7-day in primary care after discharge from the hospital. We'll try one change to our EMR or to our administrative intake system to try to change that. But this one, and we'll run it for a year. It doesn't set us up for nimbleness and trying different things. So again, 5, 6 out of 10 on some of these. I think we need to do better. And finally, our tolerance for failure, and I suspect this is true in the US as well, partly because we're worried about lawsuits, partly because the stakes feel high, partly because it's so politicized and you can end up on the front page of the paper. For lots of good reasons, we have a hard time talking about failure. But if we can't talk about failure, we can't talk about better, because the premise of better is we're not exactly where we need to be now. That's the problem. If we just consistently feel our quality is good or good enough, then why do we need to focus on improvement? Why do we need to take a hard look at the type of data that the experts in this room generate and pose hard questions to clinicians and to system leaders when it acknowledges that our starting point is not perfect? And so that's why I think part of the change process is having an environment and a context where we use and work with researchers, we work with policy people to create an ongoing process of change. So again, I think we're doing a lot of good things. I think those 6 items have really set a foundation that we can build upon, but I think we have farther to go. And I do believe that the work of the type of expertise in this room are things that we will rely upon. So I thank you very much for the opportunity to present today.
Terrific talk. I'm Martin Dawes from Vancouver, previously from the UK.
I know you well, sir. Yes.
Been doing audits since, because they're called audits in the UK, not quality, since '92. We've just been asked by our Minister of Health to describe, so our Federal Minister of Health, which is interesting in Canada, she asked us to tell her what the state of the quality of mental health was in our provinces. The problem, and I think it comes from the data from the UK, quality outcome framework actually didn't reduce mortality. It was a big splash. They spent billions on this. And what the issue we're not addressing, although you did slightly, is we're running 200 or 300,000 different systems of primary care in Canada. And so you don't get one answer to the Minister of Health about what quality of mental health is. And that's disturbing for her. How do we actually communicate that, but yet at the same time reassure her that we are delivering quality?
Yes, thank you for the easy question. Next. I think it is super challenging, and I think it's actually a nice opening question because it reveals, particularly for American colleagues, a bit of an unspoken reality about our Canadian healthcare system. I think there is a perception that it is sort of a monolithic entity with a tremendous degree of centralization. And again, if we talk to the Americans, we say, boy, you're decentralized and you have no system. We just have a single-payer system. We have a single-payer system and 1 million models and 1 million ways of doing this. And so we actually lose what I would call the competitive advantage that we would have over other systems by not capitalizing on it. I think there's a couple thoughts I have to try to answer your question more specifically. One is I think we need to we need to acknowledge the difference, but search harder for the commonality and the core. Because I do think as much as we want to argue that Northern Ontario is different from Southern Ontario and that my downtown inner city is different from your East Hastings downtown east side in Vancouver, where I spent a modest amount of time, a small amount of time, there is more commonality than difference. And if we spend too much time focusing on the outlier differences and not the large amount that actually is common, so that then what happens is we're not collecting the same data, we're not focusing on the same indicators, we're not looking to the successful funding models. We're not setting ourselves up for spread and scale so that when somebody does something right in Vancouver, Ontario, instead of having to say, well, we're Ontario, we have to reinvent the wheel, we just borrow it. I think we need to find more time on the commonality and have less tolerance for unwarranted variation. And we have to give up some of our egos around saying, well, Ontario invented it, this is ours.
So practices like me approach.
Practices like me would be a nice example. So I think that would be a very good example we could learn from others. And it does require a letting go of ego a little bit. Not ego in the worst sense, but ego in that sense of, I've got to solve this for myself, not when somebody else has solved this. And I do hope our federal government uses its current conversations to create a greater common foundation for some of this to happen. They do have a role to play. I don't know if you agree. But
my question relates to something you said earlier about having patients involved in creating some of your metrics. I believe you alluded to that. And I wondered if you could expand a little bit about how that process has affected the kinds of primary care metrics that you are measuring. For instance, is there any movement away from disease-oriented metrics towards patient-reported outcome types of experiences?
So, there's a few other folks in the room who will also comment on this, I suspect. I do believe we are shifting more towards proms. I do believe we are shifting both nationally and at the provincial level. I think we're doing a lot better. I do think we are doing better at making sure that our survey tools and our survey questions are benefiting from the perspective of patients. I think the other thing we're trying to work on in Ontario right now is patient experience measures that try to capture an experience across settings. Because right now what we tend to do is we capture somebody's experience within a hospital. We'll measure them, we'll send them a survey 2 weeks later or a month later. Or if they come to our primary care practice, we might pick some of our 12 questions. But for some of our patients, what they actually feel is the cumulative effect of moving through a course of care that might touch on several things, like a fractured hip. They break their hip and they get transported by ambulance, they end up in emerge, then they're up to the OR, then they're off to rehab, then they're in primary care, and then they get some home care. And so at any point of it, they might feel not too bad about it, but what did that sort of 6 months of acute and rehab feel and look like? And how do we capture a patient experience that reflects a course of care or a COPD exacerbation? That again might have 3 or 4 elements to it, as opposed to just saying, when you showed up in emerge, were you seen in 4 hours and were you happy with it? That doesn't capture the full experience. So I think more to do. I would say I feel we're still in the somewhat early days, and I feel other jurisdictions that I read about are a little bit farther ahead, including parts of the United States for sure. But I do believe at least they're at the table, they're adding their voices, and I think we are evolving along the curve appropriately.
Thank you for your talk. I'm Jackie Halliday from North Carolina. Our health system has devoted a lot of money and energy into training leaders in quality improvement. It's been a blast to be part of it, but I thought I'd ask you a process question and then kind of an opinion. You shared with the last speaker some of the stuff you do. Can you give us a couple nuggets about what that quality improvement leadership structure is? What's the time and commitment? Just a few things about if you're really going to do that. What was your experience to train these leaders to get to the point where they could go back and do this? My second, and I'll remind you of it, is do you think that this need for spread is teachable and trainable within that QI leadership? So is that the next place that your QI leadership program needs to kind of go to enhance the spread? So first is just process, give us a few nuggets, and then your opinion on if you can teach the spread.
Yeah. So those are both good questions. On the first one, I think it's hard to give a lot of nuggets because our healthcare system looks so different in different places. And again, I think about the family practice that Rick and myself are a member of, which is the largest academic family practice in the province. There's about 80 doctors, just under, I think. And we actually have 2 or 3 people who just focus on, not just, but have a huge amount of protected time for quality improvement. We have a lot of resources. We're within a large teaching hospital, so we have their ITIS systems. So the type of sort of nuggets, I would say, in that environment look very different from sort of a small town, community-based, with 4 family doctors, 1 nurse, no nurse practitioner, and what does quality improvement look like in that environment as well. And so part of the challenge is that. Now, what I would say, a couple nuggets, perhaps at a slightly higher, so it's hard to say, like, do you need a 0.1 FTE or a 0.3 FTE? It's hard to say that we know that because it's just so darn varied. What I will say are 2 or 3 quick thoughts. One is that data is paramount. It's very hard to have quality improvement efforts without information, and we have to make sure the information is trusted by the physicians or whoever's receiving it. It has to be regular. It has to be timely. We're giving people, I was responsible for readmission data. Our readmission at a hospital, I was the executive. So our data lagged 18 months. So I would go out to the group of clinicians and say, we're not doing that well on readmission. They're like, oh, that was 18 months ago. We fixed it. And I'd go back, 6 months later and say, we don't seem to have improved. They're like, oh, I'm sorry, that was 18 months ago. Trust me, we got it nailed. So, it wasn't timely, et cetera. And they said, and by the way, the data's not clean. We're coding UTIs the same as urosepsis, so your data's wrong, right? And you're like, oh, okay. So that's number one, data. How do we give it to our QI experts? Because that's the cornerstone. The other thing is, and this is a bit softer, but we have to give them support. So what we found is we put these people through these courses, and they're in a bunch of like-minded people, and they get really fired up, and then they go back to the harsh reality of the front lines, and they just get beaten down. And so what we've actually found is creating this alumni structure is really important for our clinical leaders in quality improvement, because they need to have the support of like-minded people to go back, to bounce things ideas, because it's really, really hard work. And if they come in for 5 days, get fired up, and you pitch them back out, they just get chewed up, burned out, and they don't do it. And then the final thing I would say is it is an intra-professional effort. And so the need to bring in sort of hardcore researchers, good policy people, true QI science, Sharon Strauss people. There's not just one phenotype here. It's a team. And so I think, again, if you set one person up, it doesn't work as well as if you can create some type of varied skill set. It's hard to say everybody can do this. On the other one, quickly, I realize at the time, I use the word spread on this slide because that's what the article used. But I think it's very important that we talk about the difference between spreading and scaling. And they are actually very different. And, we need to separate out the two. And scaling is very different from spreading. And the first step to setting up our leaders for success is understanding when you're spreading and when you're scaling, and what are the different tools you use for each. Because they are very different. And if you try to set up a frontline leader to do scale, they can't. By the definition, scaling is not going to be successful. So we need to be much more thoughtful about understanding spreading and scaling. What do you use for each one? When do you use each one? And not to set people up for failure by misunderstanding or conflating the terms, which is easy to do in common parlance.